Hi, this is Larry Bauer. I'm Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased today to introduce a few people who we will be talking with Dr. David West, a family physician, who came to Grand Junction, Colorado, to found a family medicine residency program some years ago. He also started a two-doctor practice that became the largest primary care practice in Western Colorado, and he also served as Associate Dean of a medical school that was going to begin in Colorado. Dr. West, thank you so much for joining with us.
Thank you, Larry.
Let me also introduce Dr. Pat Tokars, a family physician in Alexandria, Virginia for 40 years, and for 45 years has been a student of healthcare organization and development. Thank you for joining us, Dr. Tokars.
Thank you, Larry. It's my pleasure to be here.
And let me also introduce Allie Abel, a fourth-year medical student at Albany Medical College, who is going to start our questions for Dr. West. Allie, thanks for joining us.
Yep, thank you for having me, Larry. So Dr. West, it's a pleasure to talk to you. My first question is as a background for our listeners. Where did you grow up and what led you to medical school?
I was born in Sacramento, California, and my father did mostly laboring type jobs until he got called up into the United States Air Force in the Cuban Missile Crisis. And thereafter, we moved many times. I went to 6 different schools between 9th grade and 12th grade, finally doing most of my schooling in Ankara, Turkey, and graduated in a suburb of Washington, D.C., Camp Springs, Maryland. I then went to the University of California, Davis for medical school and got a Bachelor of Science degree in biochemistry. Then I went to the UCLA School of Medicine in Los Angeles, and I went into the MD PhD program with my life's goal to be a researcher in a academic medical center until I discovered clinical medicine. And I loved everything I took as a 3rd and 4th year student. And I saw family medicine as kind of a new movement in America. And this was in the early 70s. And so I saw it both with the spirit and the vigor of wanting to help remake American medicine, and finally completed my training at the University of Colorado School of Medicine, Family Medicine Residency Program, and ended up in Grand Junction, Colorado.
Cool. And then could you tell us about the beginning of your career and what led you to what you're doing now in Grand Junction?
Yes, I was, while a resident at the University of Colorado, Dr. Roger Schenkel was a younger family doctor from Grand Junction, Colorado, and he met me and talked me into coming to Grand Junction to see the startup of a family medicine residency program there. And so he recruited me to come, and for 2 years I was working paid by the hospital, St. Mary's Hospital, and I joined the one other faculty member, Dr. Ed Ellenwood, and together we started this new family medicine residency. There were only very few family medicine residencies in this some bill had been passed to enable it in the state of Colorado, and a new program opened in Fort Collins and one in Grand Junction at that time.
So, Dr. West, if I could ask, would you move forward just a little bit and talk about, Mesa County and Grand Junction got a lot of national attention from Atul Gawande, from T.R. Reid, a number of other people, for the great success that you had in developing something that was really quite innovative. And I'm wondering if you could speak to the early beginnings of that success, and what is it that allowed Grand Junction to become so successful?
There are several key points. One is establishment of this family medicine residency, which initially graduated 4 residents per year, later grew to 6 residents per year, and today graduates 9 residents per year. That most all the graduates, 2/3 of them, end up staying in Grand Junction, Mesa County, and I think that was one big key element. The second was the family physicians in the early 1970s were the predominant group of doctors in Mesa County, and they heard about this new federal program to form HMOs. And together, a group of real physician leaders started Rocky Mountain HMO, which was one of the first federally qualified not-for-profit HMOs in the United States. And that was really key to have an insurance company that was nonprofit and community-based.
And who was involved in that? Was it, you mentioned the family physicians, were there also business leaders? Did employers get involved in this?
Actually, it was way predominantly the family physicians. Dr. Ed Ellenwood was this family doctor in town. He had practiced in a very rural part of Colorado where uranium miners had been and had moved to Grand Junction. A very forward-thinking person. And Roger Schenkel, who was a young family medicine residency educated younger physician, and those two were the instrumental leaders. But they also had help from some specialists, an orthopedic surgeon and a dermatologist were helpful, and they basically went about starting this HMO. And I remember Dr. Ellenwood, the family physician, proudly saying that he signed the note of the money from the federal government to establish Rocky Mountain HMO.
So, would you speak to the culture that was created early on? It was a unique organization.
Yes, I think a key thing that helped us as well was the geographic isolation. Grand Junction is the largest city between basically Denver and Salt Lake City, Utah, and it's about 250 miles over mountain passes to get to both of those areas. And it's become the shopping center as well as the medical center for western Colorado and eastern Utah. And so in developing the city and the area, Mesa County has about 160,000 people today, and to develop into a regional medical center for towns like Moab, Utah, and Telluride, Colorado, and Glenwood Springs, Colorado. They wanted to build a health system that would service that community, but they also were small enough and far enough away that I think the big for-profit insurance companies, at least in the 70s and 80s, weren't that interested because there weren't that many people to be insured, and probably the geographic isolation helped. So these doctors kind of got together and said, how can we make healthcare here better? And unlike a lot of, as I see big cities and more populated areas, they kind of kick the can down the road. They say, well, Medicaid patients don't pay well, so we'll have them all go to the neighborhood health center, or they'll go to the county hospital. That didn't exist here, and these early doctors said, we will, and hospitals said, we have to take care of everyone, and how can we do that best and most efficiently? In creation of Rocky Mountain HMO, they enrolled Medicaid patients so that Medicaid patients had the same access to doctors, specialists, and hospitals as a commercially insured patient. And I think all of that really helped foster the great healthcare system that was created here.
And in addition to that, what were the other important things from your point of view that were done during the early stages of development that created a foundation that led to success?
Besides the family medicine residency program and the not-for-profit Rocky Mountain HMO, they also established the idea of a medical home long before that term was in use or became popular. And that is that every HMO patient needed to have a primary care physician in that they are signed up with. And before even seeing a specialist physician, the primary care doctor, which were about 80% family physicians and the remaining 20% being internists and pediatricians, would have to sign a referral for that. But that de facto created a medical home type model. I also think that retrospectively, we were blessed by having the right number of specialists. When I got to this community, there were very few subspecialists, and we kind of grew one cardiologist and one gastroenterologist and one neurologist, and over the years, but kept predominantly family physicians as the key members of the medical group. And per my studies on reports I did in the 1980s and 1990s, we had twice as many family physicians as was typical of the rest of the country.
Interesting. So how was behavioral health integrated as a part of this? I know it wasn't an official patient-centered medical home, but how did you address the behavioral health needs of the people?
I think in most practices came later in the 1990s and 2000s. Many family medicine offices got behavioral health folks into their practices, but not initially. But the other thing that's so critical about Grand Junction is all the key players in providing healthcare services were not for profit and talked and spoke together. So the group that does mental health services is such a group. And the hospice and palliative care of Western Colorado, now called Hope West, was started by the hospitals and the doctors groups getting together and starting this nonprofit hospice. Another key player is the Hilltop Community Services, providing care for chronically ill patients and other special services such as like access to early obstetric care. So having the key players in our community being nonprofit and to communicate with one another on a regular basis has been a real key to success.
Now, we have a number of reports that document the outcomes of this initiative, and from the point of view of better health for the community, lower cost of health care. So we have all of those statistics that we will add in with our report. But from your point of view, what were the biggest successes that you're most proud of?
One is to have a Medicaid patient treated like any other privately insured patient. That was, I had worked in Los Angeles in medical school and in Denver in residency and knew how, depending on if you were a Medicaid patient, who would take care of you and who would not. And I'm most proud of the fact that for all these years in Grand Junction, that Medicaid patients could go to any primary care physician they wanted to, and those primary care physicians in turn could refer to about 85% of the specialty doctors in town and to either of two hospitals. I thought that was a really good thing. The other kind of thing I'm proud of is how we today spend so much money on bureaucracy of healthcare, and we talk about what doctors have to go through to get a certain test done, that the insurance company has to approve it, or what drugs are on this insurance company's formulary, and on it goes. That's why our administrative costs for doctors and for our entire healthcare system are so exorbitantly high in the United States. But I would say in my private practice in the 1980s and 90s, about 90% of my Medicare, my Medicaid, and my privately insured patients were part of this not-profit Rocky Mountain Health Plans, Rocky Mountain HMO organization. So there's one way of doing things, greatly simplifying the bureaucracy that today inflicts so many aspects of our healthcare system.
Explain that a little bit more if you could, David. So did the HMO basically serve as the intermediary? They sort of collected all the Medicare, the Medicaid, the private pay patients, and they homogenized them so that by the time they went to the doctors, they were getting a universal fee schedule. Is that how it worked?
Exactly. You would get paid the exact same rate for a Medicare patient, a Medicaid patient, or a privately insured patient.
And that worked out the same for the specialists as well with their fees?
Yes, it did. And I would congratulate my specialty colleagues that they would reduce in certain ways the fees they got paid to make up for the difference that the HMO would lose for with the state contracts with Medicaid or the federal contracts with Medicare.
So, and as I recall reading in one of the reports that you shared with us, do I understand it correctly that for the docs who were involved in the administrative activity, working with the health plan, et cetera, they were actually paid for their time? Was that correct?
Yes. There were numerous kinds of committees and functions to educate and to make us aware of cost and quality information. So again, with having a large market share, I guess insurance people would call it, most patients being in Rocky Mountain health plans, they would collect all types of information and then share it with the entirety of the physician group. So I might get a posting of orthopedic surgeons and discover that this one orthopedic surgeon, the cost for a knee replacement surgery was twice as much as the other 5 orthopedic surgeons. Likewise, the orthopedic surgeon could get a list saying that this doctor's, family doctor's costs are much higher than their colleagues. And that kind of sharing of information, of financial information, is, I think, absolutely key in any rational healthcare organization. And then you asked about payments, and payments to doctors to sit on a medical practice review committee. Doctors would go into other doctors' office and review their charts for the quality of care. Other committees were set up to measure vaccination rates, for instance, or mammography rates for a doctor, and then we would get printouts, but nobody expected to do this work for free in these days of creating this fantastic healthcare system.
So it sounds, David, like the HMO, Rocky, was actually the central player, sort of coordinating cooperation with all the other agencies, the hospice, the social service, the hospitals, et cetera. So it was the HMO that really was kind of the centerpiece that brought everybody else together and helped cooperate.
I would say no, it was the Mesa County Physicians Independent Practice Association, the MCPIPA, and they were the key player. They represented 85% of the doctors, and they would be involved in negotiations of prices and also but everybody talked to everybody else, and you had good leaders of heads of all of these organizations. So, for instance, you brought up the hospice. In 1993, the 2 hospitals, the IPA, Rocky Mountain Health Plans, and all got together and said, instead of all of us having our own separate little hospices, let's put together one for the whole community, and they did so and did it as a not-for-profit hospice. And Hope West Hospice of Western Colorado, I think by most people in the field, say it is the best hospice care in the United States. And I'm biased. I'm been working for them for a decade, but I'm very proud of that organization, and it does a fantastic job in end-of-life care.
Thank you.
So, Dr. West, things today in your neck of the woods aren't quite where they were some years ago. What happened to the plan over time? Was there? I had the sense that there was a kind of downward spiral. Is that fair to say?
Yes.
And what led to that?
One was Rocky Mountain HMO became Rocky Mountain Health Plans, and then they started doing business over the entire state of Colorado. I was not a part of that, but I see that instead of having our health plan and great communication with all the area players, by becoming bigger, it became more like a corporatization, and they were later bought by a for-profit health insurance company. That's really sad from my standpoint. The second thing was a backing down on Medicaid and this equitability. So for years and years, the reality was you got paid the same, whatever your specialty for a Medicaid or a private pay patient, but they had to reduce those fees, and I think that meant lower reimbursement and created the problem that exists all over the country. Another step was hospitals. When I came to Grand Junction, hospitals by law could not hire physicians. Those laws were changed, and hospitals, including our local hospitals, began not supporting independent physicians and became much more aggressive in hiring their own physicians. And I think that has been quite damaging. And finally, I think primary care physicians are so much office-based today. They don't go to the hospital to see their patients. They don't deliver babies near as much. They don't even attend meetings near as much. It's kind of a both an attitudinal change and a financial realities have done this to primary care. But those four things I just mentioned, I think, are all part of the downward spiral, and we're becoming as expensive as the rest of the country.
So if you had to do it over, or if your community had to do it over, what would you do different that might have averted the downward spiral?
That's a very good question and a very hard one to answer. I think that all healthcare entities in the country should be locally run and not for profit. And when I say locally run, I mean have the regional health plan taking care of maybe up to 1 million people. That seems to be an efficient number for spreading risk and not losing the size efficiency. And the idea that that you're running a health insurance company to make profit for stockholders is just abhorrent to me, and we're the only country on earth that does that, to my understanding. The second thing I would do is I think doctors should remain very much involved with the administration of healthcare systems and play the instrumental role that was done in the 70s, 80s, 90s, and 2000s in Mesa County and Grand Junction, Colorado, and how to enforce that. But to me, it's just part of the ethics, and we need to look at the entire reimbursement schemes of all of medicine. The third thing is throughout my entire now almost 50-year career in family medicine, that why we train so many specialists and train so few primary care physicians is just crazy to me, and I think that needs to be changed. That one statistic I saw preparing for this was 6% of U.S. medical school graduates go into family medicine. 55% do in the United Kingdom, and that needs to be changed to educating a lot more family physicians and primary care physicians.
Well, I think we couldn't agree with you more. I did have one other question. Are there any other communities or areas that followed your example and tried to adapt the principles that generated so much success in your community?
Well, Grand Junction got famous in about 2007, 8, 9, 10. President Obama came to Grand Junction, and the New America Foundation came and studied us, and people wrote articles in journals and magazines. And following that, I participated in that a little bit and went to Louisiana, and I went to Upper Peninsula, Michigan, and I went to other places in the United States, one trip in North Carolina, talking to health communities about the success of Grand Junction. But sadly, I cannot say that I've read about any of them making the dramatic changes that are needed to put the doctors back in control of our health system and to make health systems smaller and more locally run.
Okay. And I wonder if you might speak to the issue of preparing family physicians to become leaders. What are your thoughts about how you do that?
I thought a lot about that in preparation for this, and I don't know. I think that medical students of today are in a whole different realm than my generation. We saw healthcare reform as a movement that needed to take place, and the baby boomers, of which I'm one, I was protesting the war in Vietnam when I was in college, and when I finished residency, I was a huge advocate of family medicine and primary care right from the get-go, and of course remains so today. But I think that today's younger people are beaten down by student debt, they are just of a more more likely to accept the status quo. I read where students may be graduating on the average of around $200,000 in educational debt. It's too expensive to start your own practice, etc. So I don't fault the young people of today, but I think that only a very dramatic, probably government-led reform is going to get America out of this mess that we're in today, and hopefully doctors can play a much more active role. Furthermore, I'd comment that I was very active in physician groups of the American Academy of Family Physicians and the American Medical Association and the Colorado Medical Society and groups like that, trying to bring about reforms. And those groups, I think, have let us down by not being much more proactive. And I always said that I think that I could sit down with a group of 10 family physicians and devise a much better healthcare system than the one that we all practice in today. But sadly, these redesigns are being done by economists and bankers and politicians. And all my trips to Washington, D.C. and lobbying, it just kind of, where is medicine and how do we establish a strong voice of physicians that can lead the charge to a better healthcare system? It doesn't have to be Elizabeth Warren or Bernie Sanders. It should be doctors out there, and we need to do that. But how to get that done, I don't know how to do it.
Dr. West, would it be a matter of medical students and residents getting behind and supporting some of these political campaigns? Would that be an idea? I'm just trying to think of other ways we can get involved as advocates.
Well, the first thing yes, but that's a tough road to follow because
Right.
National politics is so complicated and all the conflicting issues that come up. I think instead, if I were a young medical student today, I'd put my efforts into reforming the AMA, reforming the AAFP, reforming the Society of Teachers of Family Medicine, getting those organizations, their leadership structure is such that the people that are elected into power positions usually serve just 1 year, like board chair or president, and then they are kind of out, and then a new one comes in. And they also are assigned all sorts of public relations kind of activities. Go to this meeting, go to that meeting, give a speech to this group, talk to the TV about this issue. Instead, if we could get our healthcare organizations to say, we want to spend 6 months and we're going to meet 10 different times or 5 times, and we are going to write a comprehensive plan to fix American medicine. I think it could be done by medical students. I think it could be done by residents. I think it could be done by practicing doctors, and do a heck of a good job. That's where I just think that the voice of medicine is absent, despite the fact that medicine consumes, 22% of our gross domestic product, and is by far the biggest business on earth.
Right.
The
And
doc-
if the voice of medicine, if the voice of medicine is not being heard, the voice of family medicine is definitely not being heard. So, interesting.
Dr.
Thank you.
Tokars, Dr. Tokars,
Yes,
any further questions?
well, I've got lots of questions. A couple of specific ones and then some more general ones. I've seen around the country similar approaches to have local cooperative organization of healthcare for the local community in the federally qualified health centers. What's been your experience with them, and are they a model that we should expand to more people?
I really don't feel qualified to answer that, Pat, because there has not been a federally qualified health center here until just very recently, and I'm not involved with that. I do have friends that practice in Denver area that are employed by such groups, but again, I don't see that. I'd say, as sort of a caveat to your question, is that what I see as the most successful groups are perhaps Mayo Clinic, Geisinger Clinic, group health cooperatives, groups that they have a certain income, and then they provide all the health care to this large population of people. Sadly, what they don't do is they don't include 100% of the citizens that live around them or in their immediate area, but they do have the efficiencies of bureaucracy, being one bureaucracy to deal with, not 10 or 20, and one insurance carrier, one payer to deal with, not a whole bunch, and selected hospitals, selected specialists, etc. That model is, I see, the most similar to what was done in Grand Junction in the past. But you have to have a health plan that takes care of the entire population in an area. I am all for regionally run, regionally operated, not-for-profit health care. I don't want to call them insurers, but healthcare managers and payers of healthcare.
Thank you. Like you, Northern Virginia, we've gone through over the last 40 years succession of HMOs, PPOs, physician hospital organizations, IPAs. In my experience, they all followed similar paths of yours, where we started out with ideals, started out with success, and were gradually ground down by the people we were trying to replace. In other words, the Blue Cross Blue Shields and the hospital systems sort of took them over and turned them into what we have today. There was some hope that the accountable care organizations, particularly the physician-run and directed accountable care organizations, might be a new way of organizing for regional care for a defined population of people with some of the same cooperation and success that you experience in Mesa County. Have you seen any of these accountable care organizations that you're aware of around the country that are actually functioning and maybe leading the way in this transformation?
Yes, but again, I don't, and like our friend Joe Sugar in Palm Springs or Palm Desert in California in the Eisenhower Medical Center, he told me stories of success that they brought about with primary care and that sort of model, as I understand it, but I don't know too many details about that. And I think it's fallacy to kind of build a new healthcare system with the model of this group is taking care of this group of patients, and that group is taking care of that group of patients. I really think we'll only have success when we do it the way the rest of the world does, that everyone is covered by their system, and the care is hence not as confusing. My son lives in Paris, France, and I think they just have a marvelous system of healthcare in France, and all the issues that plague doctors, like here, that getting information of past medical records is not a problem there, and who to go to is not a problem there. So again, and for Allie to kind of answer her, the first thing I would do if I were President of the United States and was in charge of getting a better healthcare system is I'd send people around the world, and I know our colleague has done that with his TR Reid Sick Around the World, but to look at what's good and bad about other systems and use those principles you learn in rewriting how to do better healthcare in the United States.
So, Dr.
So it
Tokars,
sounds,
we have time for one more question.
well, it sounds, David, like you're sort of describing a universal health care system for this country, but organized with a lot of autonomy on the local, regional level, with a lot of physician-led control over what happens locally to the patients. Is that a fair summary?
Yes, exactly. I think the federal government could actuarially pay regions for their present amount of money that they put into healthcare, which is around 60% or so, and you could just base it on a 1-year-old girl would be paid this amount to the health plan, and a 99-year-old man would be this amount, all that actuarially determined from older records, and then the regional health plans get that money. They have to raise the rest of the money from the citizens that they're serving, and then these regional health plans would be voted on by the residents. So if you're real unhappy with your health system in your community, you vote them out of office and get a different one. And you'd have to have federal backup with oversights and some general capacity. But I think designing healthcare for Wyoming is a whole lot different than designing healthcare for Los Angeles or New York City. And the idea that we can have Medicare for all, which is, if that means a structured program like Medicare, will never work. You have to have local decision-making, local control, local quality, and all of that needs to be part of a new and better American healthcare system.
And have you written your ideas along these lines out recently that we could steal from you?
I did it about 10 years ago, and now I'm redoing it and working feverishly on such a article or publication. So, yes, sir.
Well, good. Well, number one, thank you so much for your leadership throughout your whole 50 years. I was really impressed with the articles out in 08 and 09, and I'm thrilled to be able to meet you today and to find out that you're continuing to work on these issues and try to help the rest of us come up with some solutions, because we are in your debt, and hopefully we can continue working with you to spread your ideas for the rest of the country.
Thank you, Pat.
Thank you very much.